I think it's a minute after 4. Can we settle? My name is Refilwe Maji, and I'm from URC. I'm currently based in South Africa, currently working as the acting chief of party for the USA TB South Africa project. And we have several programs in the region and globally. I'll be co-chairing this session with Dr. Hinsati, and I'll hand over the microphone to introduce herself also.
Good afternoon, everybody. My name is Hinsati. I'm the Senior Technical Advisor for URC. I just recently joined URC from Partners in Health. And I worked on MDR-TB and TB-HIV for over 11 years. Worked also through the regional GLC in multiple African countries, over 20 countries in Africa. So it is my pleasure to be with you today. So we are moving now with our presentation, and our first presentation is going to be presented by Refilwe Maji, and she's going to speak to us on the community-based MDR-TB care lessons from field implementation, and she will share the experience of TB care too.
Is it noisy, or am I imagining there's noise somewhere? Okay. If it's acceptable, but because I really feel the noise, and unfortunately some of these platforms are not very conducive. I feel I'm somehow under this, but anyway, let's move on. So my presentation today really will mainly focus on some of the lessons in introducing community-based MDR-TB under TB Care 2 in South Africa and Bangladesh. And before even talking about Bangladesh, I must say that this is the work that finished around 2012. So some of the data that will be projected here, it's a bit old. That's interesting. So the outline, really, I'll just be literal about the background, why community-based MDR-TB, how did we go about it, and some of the results and conclusion. I think all of us here, we are aware and have seen this slide several times, but what is important is also to note that the two countries we'll be talking about are part of the 30 high burden countries, Bangladesh being high on TB and multi-drug resistant TB, and unfortunately South Africa, high TB, high MDR-TB, and high TB-HIV. This is again a slide that we have seen several times, that from the WHO showing the gap from the estimated to the detected, and those started on treatment, and ending up with a treatment success rate of 52%. And out of those detected, really the simplest way of translating it, I think out of 10 patients that are detected, 1 or 2 end up being successfully treated. Now that's global. Now we look at South Africa, again based on the WHO report, 26,000 cases were estimated, and the country only detected about 79% of those. And there's documentation that only 13,000 of those were initiated on treatment in 2015. And for 2013, the treatment success was just about 52%, which really is not so different from the global trends, which are not good. Now for Bangladesh, 5,100 estimated, and detected, it says that only 18%, 954 cases. And in 2015, 92% of those detected were initiated on treatment with a treatment success of 75%. Now, again, this is a slide that many of us are aware of, showing that, unfortunately, with the long duration of treatment, within no time, especially after 6 months of taking treatment, patients stop taking treatment. And in the past, this is the time when patients would be in hospital, but once they leave the hospitals, the treatment interruption increases rapidly. Now, specifically looking at South Africa, what are some of the challenges? I'm not sure if we're able to correct the slide from the back there, but some of the programmatic challenges is, firstly, was the long waiting time from commencement of treatment to initiation of treatment. Initial loss to follow up, and for drug-sensitive TB, currently standing up around 15%. So these are patients who were diagnosed but were never documented as being initiated on treatment. And the current hospital model, there's no way that patients would be able to be provided support at community level to complete treatment. We know about the long duration of treatment. What are some of the programmatic challenges? The poor treatment outcomes for drug-resistant TB. And really, I think it's still unacceptable that with the new drugs that are available, 1 in 2 of these patients who start on treatment do not complete. The drug-resistant TB transmission within the facilities we are aware of, and our current hospital models are not patient-centered care. At communities, the costs to the patients and to the families are huge. There are issues around knowledge of tuberculosis, and unfortunately, stigma still plays a major role. Now, I'm bringing up this slide. Sometime this year, there was a mission from the WHO that was in South Africa reviewing the MDR-TB program, and they looked at some of the data from 2007 to 2014. But I think one of the good things that had happened is the closing the gap between the diagnosed and the enrolled on treatment. And this really happened because of the decentralization, because patients had to be on waiting list before initiated on treatment. But from the time that decentralization was introduced, this time was reduced. And what were some of the major findings? The high initial loss to follow up. As we've talked about the gap between the diagnosed, it was 55% in 2007. And by 2014, the program had been able to reduce it to 36%. And here again, they just highlight the drop in 2013, and it was not clear what happened there, whether it's an issue of reporting or recording. This is based on the South African guidelines, this is the model for care for decentralized management. In each and every province, there are decentralized units, but the patient is managed at home by community healthcare workers, and these are some of their responsibilities. Also, there are counselors and social workers who work with the families to provide the adherence support for the patients. So what is being presented here is the work that has been supported through the project for the past 1 year, where NGOs are being attached to several decentralized sites to manage the patients, especially the provision of injections during the first 6 months of treatment. So to date, again, to show what is some of the successes out of the 914 patients, 94% of those patients are still on care. Very little loss to follow up, less than 1%. Unfortunately, we have about 8% of those patients that died. But the good thing here, again, is the management of side effects, that the NGOs have been trained to identify both major and minor side effects. And to date, about 4,342 side effects have been reported, and the NGOs know when to refer the patients to hospitals or when to manage minor side effects at home. But just really in conclusion, looking at South Africa, these are some of the examples of the work that is being done by the nurses and the community healthcare workers. And the quotes from the patients, one thing that the patients really found helpful was the continuous support while taking the medication. And also they appreciated that there's someone who comes to the house on a daily basis to ask them how are they feeling, how are they doing, and also to be motivated to take or continue treatment. And many of the patients have also highlighted the issue that when they're told they have to be injected on a daily basis for 6 months, that's very daunting, but it's just that support was helpful. And this again was a quote from a patient. It says, "I am very happy now with the support I get from my caregivers. It's sometimes difficult to go to the clinic. I do not know who to leave my children with, but now I know the caregiver comes to my house." These are again minor things, but when you look at how much they help the patients to continue treatment, we need not to take them lightly. So what are the progress to date? The good thing again for South Africa is that there is a national guideline on decentralization. Each and every province has a provincial plan, and also now there's utilization of already existing mechanisms within the country, which are these ward-based outreach teams that do not only manage multi-drug resistant TB, but programs like maternal and child health. There's access to audiology services, there's support for quality improvement, and also there are plans to expand the services to hard-to-reach areas. And as part of that, South Africa has got one of the biggest programs for the introduction of the new regiments. Just quickly again talking about Bangladesh, when the project started, this was initially piloted in 4 districts, and the first patient was enrolled in May 2012. And by the end, the CPMDT was already expanded from 4 districts to 38 districts. Now, again, through the project, the criteria was set up. How are these community healthcare workers, how are they selected? But again, they had to go through intensive training to ensure that they are committed to managing the patients. Just to highlight one of the major achievements from the introduction of community-based MDR-TB in Bangladesh, initially there was only one site at the NIDCH in Dhaka, but within that time from 2011 to 2015, treatment initiation from the time of diagnosis on average was reduced from 69 days to 5 days, which I think was also a major achievement. And again, looking at the additional benefits is closing the gap between the diagnosed and the enrolled, looking at from 2011, and by 2015, almost all the patients who were diagnosed with MDR-TB were initiated on treatment. My colleague later will talk about some of the technologies that have been introduced to manage patients on community-based care. I think one that I would like again to highlight in South Africa, that with just the use of the technologies, one has been able to do GIS mapping for the patients. And this is an example from one of the districts, one NGO that was supporting the patients. Just after doing the GIS mapping, it was clear where the transmission was happening. And the next step was now to go to those communities to do active screening within the communities to find the additional cases. I think this I'll leave out. My colleague will talk more about it, about Bangladesh. And in conclusion, I think what the lesson I again learned is community management of drug-resistant TB is feasible. It does improve treatment outcomes. The results are very good. And also, it empowers patients and communities to be responsible for their lives. But moving forward, we need again to emphasize that governments need to invest in comprehensive integrated community programs than running parallel programs. TB, HIV, maternal child health services, non-communicable diseases, these are all activities that communities need to be empowered to manage. And all of this will ensure that we achieve our universal health coverage. I think that's my last slide. Thank you. So we seem to be taking turns introducing each other. Now this is again an opportunity to move to our next presentation, Dr. Hinsati, who will be presenting on the short treatment regimen introductions in high-burden countries. And
thank you, Rifelwe. I'm going actually to take you through the very short project that was supported under TB Care 2 from January to September in 4 countries. And I'm going to take you through some of the achievement within very short time and how systemic support to countries and to national TB program can move them from non-patients on treatment to actually patients on treatment. So the goal of the project, of course, was to support the national TB program, and this was the 4 main objectives that was set for the for very short project. It is to provide technical assistance, and the technical assistance targeting the national TB program in these proposed countries to allow them and support them to overcome the bottlenecks on providing the RTB services, and to improve the pharmacovigilance, which was one of the bottlenecks that the countries was actually facing to introduce the new TB drugs as well as the shorter MDR TB regimen. The third one, to strengthen the site capacity to diagnose the RTB and to introduce the different molecular testing, and hopefully this will continue through the next 3 years. And the last objective is to demonstrate and disseminate the best practices that achieve from those small countries. So the major expected outcomes, one of the areas that was identified in the gap analysis, that most of these countries, they did not update the guidelines to be in the same line with the global recommendation, and as well to have the ability to develop the SOPs and job aids for clinicians to be trained and to be able to provide these services, to establish the national pharmacovigilance system for the shorter regimen and for new TB drugs, as well as to build the capacity to diagnose and to decrease the loss to follow-up and utilize other available funding, either from Global Fund or USAID or from any other funding in the countries that is underutilized. So all those countries use the same framework, and they design it together and focusing on actually active case finding. And the main area of active case finding, it is either at the community or the health facility, and there is different intervention designed for each country with the national TB program actually plans on how to improve the active case finding. The second one, it is enrollment on a standard treatment or in the new drugs or shorter regimen, either the community or the facility according to the national guidelines. The last one is the follow-up and prevention, and this is focusing on actually improving adherence to treatment as well as providing different social support to patients and work on contact tracing. Of course, this is all built on very strong cross-cutting areas of drug supplies, which is a major issue for many of those countries, as well as staffing and so on. Supportive services will include the diagnostic and how can integrate it with HIV as well. There are different strategies listed here. I'm not going to go through them, that the countries identify themselves on how to achieve the goals and to reach their objectives. So under each of those objectives, all these countries agree on 4 objectives that they are focusing on it, but I want to highlight objective 2, really moving to more mobile technology and also using the technology to address the active monitoring for adverse events of drugs, and as well as to build a national ADSM system according to the WHO framework, and to introduce electronic medical records so it will be easier for them to handle reporting and recording and to have reports and to follow their patients. And of course, in working on the diagnostic and other things. So I will start with the first country. It is Sierra Leone, and I think we all know that this country suffered after the outbreak of Ebola and really had a very weak health system, which can serve as a platform for anything. And we saw that working on the TB, it is going to improve actually the health outcomes, and it will serve as a platform that they can actually build on it for different other health services. So, and the country, as we know, that could not actually utilize the available fund from Global Fund to initiate treatment, and they did not have a single patient on treatment until the project started. So they work with a team on with a national TB program to actually update the national guidelines, develop the SOPs, and other things to help the clinicians. And they run the national also training, which they have 43 clinicians that they are trained on drug-resistant tuberculosis, on new TB drugs, as well as the shorter MDR TB regimen, followed by initiation of the first patients, and strengthening also the transportation. And they worked out a system through this project to send samples to Germany for second-line DST, which is not available in the country, and to strengthen the gene expert. They had a lot of stockouts of cartridges, so through this project, actually, they be able to transport samples and to utilize the gene expert, which has a great improvement from the baseline. And up to date, they have 59 patients enrolled after this initiation, just working very strategic with the national TB program, addressing gaps on why they are not initiating patient on treatment, and providing direct technical assistance, either clinical or based on the policy and strategies, and they managed to put 59. This is an incredible, actually, achievement for the national TB program within very short time. They really, this is the hard work of all of them together. And one of the areas that was very challenging is to have a full-time consultant who can provide ongoing support to patients initiated on the shorter MDR TB regimen or new TB drugs in that hospital. So they still use the hospitalized model. They just now moved to decentralizing it, and they decentralized service to Kono district, and they released 12 patients from those who they are initiated. So this is some of the photos from Sierra Leone. Moving to the second one is Liberia, have the same challenges after the outbreak of Ebola with very weak health system. They had one facility that initiated patient on DRTB in Monrovia, which is a capital. So patients from all over the country, if they are diagnosed, they need actually to travel, some of them, over 170 kilometers or more, actually, to get to the one single facility for the country to be initiated. So the program, actually, the project focused on decentralizing service to allow patients to be initiated on one of the regions that has the highest, actually, high burden of TB and TB HIV, as well as DRTB, which is the southeast. And they also supported the national TB program to construct an MDR TB ward that can accommodate 16 patients, which was a requirement from the government to decentralize service to have an inpatient facility. And they conducted training for village health workers so they can be able to introduce community-based DRTB care for those patients who they are decentralized. And they also work on sputum collection training as well as transportation, which is one of the huge actually challenge for those programs in these countries. This is a newly renovated and built 16-bed facility to initiate patients on treatment, as well as some of the trainings. The third country, it is Haiti, and we know all Haiti is one of those countries really struggling still with a lot of health system issues and poor health system. So the DRTB in Haiti is supported by few partners and really heavily supported through them. So the project focused on updating the national guidelines. They were not updated, they were not in line with the WHO recommendation, and also to strengthening the diagnostic. So under this project, for the first time, actually Haiti established a second-line LPA lab at HUM hospital. And there is an increased utilization, more than 2.5 actually fault from baseline on gene expert testing, which is some of them, they are actually drug-resistant cases, which they put on treatment immediately. LPA services, which is made available through this project, is going to help the whole country to actually do a second-line testing through LPA, as well as to initiate patients on appropriate regimen immediately. And of course, working on the transportation, which was one of the biggest challenge, actually. And I have to say that the increase on gene expert testing, it's only done through this transportation system that was established. So the fourth country was Kazakhstan, and here we focus actually to support the existing NTB project that was supported by Unit 8, which is successfully was putting patients on new TB drugs. But there was a lack. We identified that we are actually missing reporting, and we came up with an innovative app, mobile ADSM app, that can help the patient from the community directly to report adverse events timely. And there is a 24-hour line to nurse and to the TB clinician at different levels who can address the challenge or that the patient is facing within 24 hours. Everything is monitored and also interface with the electronic medical records for DRTB. And through this actually initiative, we hope that this very friendly used app, it is available on Google Play. It can be actually downloaded to any smartphone. So patients, they use a smartphone, provided they use tablet, and also it will allow actually building partnership and relation with the private sector to provide services for smartphones and tablet, as well as the airtime and data plans for patients and the healthcare workers. We, up to now, reported around over 90% of adherence, because the same app can provide video DOT, which is recorded into a system, and that can be followed by the nurse, which will record everything on the electronic medical records of the patient. And the same app sends actually reminders for laboratory tests and clinical follow-ups. So this is just a demonstration of the ADSM. You can find it on the Google Play as well. So it is a very nice application. You just have to be actually given, hopefully soon it's going to be available for everybody and people can be using it. This is the same application and people training on it. So we call this project First EVA, that we hope that list will be long. So the First EVA is a treatment center in Sierra Leone that initiated patients. first ever decentralizing service in Liberia to Southeast, and first ever community-based ADSM that we are very proud of it, and first ever LPA lab in Haiti, and first ever community action to plan guide that we hope that many of the national TB program will use it to implement community-based program, which take the national TB program step by step on how to establish community-based DR TB program that is successful. So this is some of the challenges that we're facing during the implementation. I think all of us, we have challenges, but I can say that the coordination between the countries was one of the big challenges, but they can all work on the same platform as long as their goal is one. So this is some of our best practices, and thank you so much, and we hope that can be expanded in the next 3 years for other countries and sites.
I would like to call upon our next speaker, Alex Mount from URC. Alex is a senior program officer at URC and focuses on TB programs, also including programs within TB Care 2. He has experience in operations, research, design, implementation, and has worked primarily in settings in Southeast Asia and West Africa. Alex.
Okay, thank you, Rafil. Let's see if we can get this going. Okay, perfect. So we'll give a very brief introduction of a bottleneck analysis that we did on the DRTB continuum of care. So briefly, conflict of interest statement. And then today we'll start by defining the DRTB continuum of care. And then we'll go through the different determinants of bottlenecks within DRTB care programming. We'll also talk about some proxy indicators that we've defined to measure these different determinants. And we'll then take another look at the continuum of care in a different format. To wrap up, we'll talk about an example from a recent TB Care 2 meeting in South Africa. So to start, having a bit of a, is it possible to change the format here to 16 by 9? So we can continue, but looking at the initial care continuum, I think everyone's seen this. You see aspects ranging from drug susceptibility testing to diagnosis, treatment initiation, adherence, retention and care, recurrence-free survival. Of course, this isn't the only consideration in DRTB, so we have to add things like prevention, palliative care, interpersonal communication and counseling, adherence support, nutritional support, and management of comorbidities like HIV, diabetes, and others. And in defining this sort of standardized general continuum of care, our first question is where can things go wrong? Where are the bottlenecks? Where are the issues that we can see in programming? And just upon an initial examination, you can come up with plenty of different examples all over the continuum. So bottleneck analyses are traditionally used in MNCH programming. Tanahashi developed the first model years ago and looked at supply and demand constraints that create delays in care, that create inefficiencies in programming and other aspects. So this bottleneck analysis that we're presenting today uses the supply and demand level aspects that were originally introduced, but we're also adding a quality aspect and we're adding a policy or an enabling environment aspect, as those considerations are really essential in DRTB programming. So as well, in this iteration of our bottleneck analysis, we'll look at things both at the central and federal level, we'll look at provincial level, and we'll also look at the community and local levels, as these different actors and different health systems can be really important to DRTB programming and need to be measured separately in order to really understand where are the different inefficiencies in existing programs. So if we move to this slide here, we see a bunch of words, I know, but we're looking at a variety of determinants within these 4 domains. If I have it, is this? Yeah. So we have an enabling environment domain, we have a supply domain, quality, and then we have demand. And then our first understanding was what are the potential bottlenecks in general. This is kind of a general example. We would apply it at the specific country level to understand the specific continuum of care. In this setting that we say within environment as an example, we see maybe lack of awareness of DRTB, shifting priorities in health and other sectors, and also monetary and logistical inefficiencies in procurement. As well, we can say, what are the determinants of this? We would need policy and lawmaker support. We need existence of sustained funding, transparency in procurement procedures. As well, we can take this to supply. We can see what are the potential bottlenecks. Stockouts are a huge problem. Lack of equipment, lack of diagnostic tools, lack of staff, inefficient number of healthcare workers, and too few health centers. And within the quality realm, I think, we could come up with innumerable, bottlenecks here, but improper storage, lack of quality control, poor training, lack of counseling, the list could go on forever, I think, especially within the quality realm. And then in demand, we see lack of diagnostic commodities, lack of trained staff, lack of community engagement, poor IPC, drug failure, and then these specific determinants sort of track onto each of these bottlenecks. So then continuing on, our next sort of question after we've broken all of this down is how do we measure all of it? So we want to look generally within these 4 domains in the center. We'd want to measure here things at the central, things at the provincial, and things at the local levels. A lot of these, a lot of NTP programs, maybe they're central level programming, maybe they're specific provincial level programming, and community-based care is a completely separate discussion. So we have a lot of different programs happening or a lot of different programmatic aspects, and we need to be able to break that down to say where exactly are programs experiencing inefficiencies, where are programs working, or where could they be working better, essentially. For demand, we found mostly local level determinants as far as, people accessing care, people, adhering to medications, and then in the enabling environment, we would see central and local level determinants. Of course, if you're in a fully decentralized health system, you would see maybe only provincial and local level determinants, but I think that also varies very specifically within the country context. So I won't go through this massive table in great detail, but this is just sort of an example. Our next step was to say, given whatever level we have here and determinant, whether it's central or local, and then the determinant, whether it's these other, the determinants in the previous table, how can we define a proxy indicator that says, in a quantitative sense, how are we measuring this and how could we improve it? So our goal in sort of defining these indicators was to use indicators for which data already exist and things that are already being reported. So to overlay this model onto a system that already exists, to reduce burden, to utilize the existing data that we're already collecting, just to sort of minimize the time that it would take to implement this. I think that's, yeah. So there are some examples up here. I think it's, pretty standard indicators that you would see. And again, this really depends on whatever the specific country is already collecting. I think that's a major takeaway. We'll say, given the data that we have, or given these specific bottlenecks that do exist, or the specific determinants that might exist in a given country, how can we really effectively measure that? So we have, similarly, supply, I think, availability of commodities, availability of human resources, laboratory capacity, these things will all play into the adequate supply determinants. I think we can move to the quality aspect. We'll see very similar things as far as within medicines, diagnostic equipment, service delivery, and importantly, I think this is unique, the perception of quality. So whether people are accessing public or private facilities, what the quality of those facilities are, and how we can measure that effectively to understand the effectiveness and the efficiency of public programs. Okay, and then finally, within this sort of initial set of indicators by domains, we have the demand, which is mostly we only found local determinants. I think that's fairly self-explanatory as far as looking at number or proportion of patients lost to follow-up, days from diagnosis to treatment initiation, patients started on treatment, days from initial hospital or facility presentation to diagnosis, number of relapse cases, case fatality rate, things that are generally collected already at the individual level, or rather at the more local level. And then bringing this all back sort of into the continuum of care, we can use a modified, the original Tanahashi model sort of uses this stepped perception of the continuum of care, in which we'd be able to say, given our target population here at the bottom, which is theoretically all of the people we would want to reach, we can look at the steps as we go up in these different rows. We're losing our potential coverage. So within enabling environment and supply, everything to the left of this is the potential coverage. So we can cover everyone that the supply and the enabling environment would allow for, right? But we can look exactly here at the quality stage where we say, maybe we can provide for services for all of these people, but they won't necessarily be of a high quality. So then we have our potential quality curve right here. And then finally, we look at this recurrence-free cure, recurrence-free survival step right at the end of the continuum of care. and that's really our actual coverage. So if we compare that to the target population, we are, through the various ways we're categorizing these steps in programs, losing a bunch of people, whether it's before they even get to the facility or during their treatment. So in a sort of larger, more general sense, we can understand this as potential coverage to target population here with the supply and the enabling environment as our institutional gaps, and we can sort of target quality improvement and program improvement activities to the institutional side. And we can also look from potential quality coverage to actual coverage as far as our programmatic gaps, so improving those more local level determinants of care once people are actually presenting to a facility. And then initially we decided we were looking at quality here as this gap in between potential coverage and potential quality coverage, but quality really does touch all of these different determinants and all of these different domains. So we would want to look within service delivery, within supply, quality of medicines, within the actual enabling environment. We really do have to consider quality as a really overreaching perspective, although it fits specifically into a gap as far as potential coverage and potential quality coverage. We can't only look at that. We should look as well at quality within the supply chain and quality at the higher, environmental level. Excuse me. So I think with the minute I have left, I'm going to look at this example from China. We recently, with TB Care 2, had a meeting in South Africa for best practices in DRTB community care in the development of national community-based DRTB care plans. And we asked participants to sort of look at their existing programs and to look at the continuum of care in their specific context and say, what are the issues that you are experiencing and how can we sort of categorize these into our domains? So I'm going to enlarge this a bit. We see within all of these 4 domains here, we have demand, supply, quality, enabling environment. The China team was able to identify some bottlenecks that are very specific to the Chinese context, and they were able to track or at least define in a more highly organized way what is the awareness or what are the demand aspects. People aren't aware of TB, people have psychosocial needs that are not being addressed. What are the quality issues? What are the environmental issues as far as insurance schemes and covering second-line drugs? So these things that are very country-specific, we were able to sort of elucidate. And then the next steps as far as this would be to say, how can we define the proxy interventions and the proxy indicators that we can actually collect real quantitative data on to say exactly where are the bottlenecks, what are the most important factors, and what are the largest bottlenecks that are occurring within this specific continuum of care. And then with those results, you're able to say, this is really a priority area, mostly institutional gaps, mostly programmatic gaps, mostly within demand, mostly within the environmental area. So sort of organizing this in such a way that we can really, really highly specifically focus quality and program improvement activities rather than doing overarching or more general activities within quality improvement. So I think that's all of my time. I don't know if there's probably no time for questions, but feel free to send me an email if you have any follow-up questions. Thank you.
Thank you, Alex. I'll need to move on to our next presenter, Imran, who is currently working as a consultant with the URC. And I think one of the things that Imran might focus on when you think of the first presentation we had was the introduction of M-Health in Bangladesh, but he's been involved with the introduction of e-tools for patient management and patient evaluation for several countries under TB Care 2. Imran.
Thank you, Rafle. Good afternoon. I'm going to discuss on ML tools to support community-based programs. So due to development of mobile technology and wider network coverage these days, handheld devices are really widely used in healthcare, like especially community-based health service delivery. And the reason it's becoming really more popular due to real-time monitoring of field activities from central level, remote monitoring and supervision to enhance project performance, improved quality of community-based patient management through day-by-day updates from community level, interactive geomapping, and overall improved result and program outcomes. So we are going to share. I'm going to share some experiences we have from several projects on e-tools. Some successful interventions we have is TB Health, which was introduced in TB Care 2 project Bangladesh, and also Connect TB South Africa project. We had same experience, and also IP Connect, a suite of application for improving infection prevention and control, and MDR Doc, which is a video call-based communication system between patient and physician to manage ADR, adverse drug reactions. Symbol-based self-reporting tool that was really specially developed for minors. It was completely symbol-based tool for self-reporting, and e-flip chart for patient education. So the TBM Health and Connect TB tools, I'm going to give a quick description. TBM Health tool was introduced to monitor patients under community-based treatment, MDR TB patients, to manage day-by-day treatment, ADR, adverse drug reaction, and for patient counseling. TB Care to introduce a TBM Health application to support program to ensure quality ., facilitate a rapid response to advanced drug reactions. So this is the how it works. A smartphone was given to all DOT providers to report from patient's house to ensure their presence to the patient's house, and also what drugs they are taking every day by day. Any adverse reaction was experienced by the patient. So everything was recorded via this mobile application, and it was captured in a central server, and it was monitored by the program personnels and government program personnels from central level. So these are the few screenshots of the application we had in Bangladesh. As you can see, the list of medications and the adverse drug reactions. So this is a real-time monitoring dashboard which was used by the program managers to view the performance of the field activity every day. These are the real-time information that we can see easily, like adverse side effects was reported from the field by each patient, geotag to ensure that the DOT provider was really to the patient's house, and also patients by gender, and also the result. So as you can see on this graph, the difference between before initiation of TBM Health and after that, it really improved the quality of care at the community level. So this is a cohort analysis we performed based on a district in Bangladesh, Chittagong district, based on the patients registered in 2013. And the result was really outstanding. I mean, we managed to have 0 dropouts from the patients under mHealth network. As you can see the graph, and of course discontinuation was completely 0. So similar modality we tried to adopt in TB project in South Africa. So this is same as smartphone-based application, same as TBM Health, which is used for to report day-by-day patient status from community level. But they are using both for DSTB and DRTB patients, and to manage adverse drug reactions. So these are the results. I'm actually going, due to shortage of time, I'm not going deep down to the graphs. So as you can see, the follow-ups and the adverse drug reactions reporting reports. So here is a patient in our community, in South Africa project. So all patients are geo-mapped. So we have a map on patients that where the patients are located. So there is a comparison was again conducted in South Africa between whole country and the area, districts was covered by Connect TB. So this is a comparison result that there was 0% loss to follow-up among the patients were registered under Connect TB. So there are some results. So far we have done, this is quite 802 DRTB patients since 2015. Adherence rate was 98%. Side effect managed really well. 1,561 side effects was reported. And we had managed to identified 261 child contacts. So this is another tool we are going to discuss about, IP Connect. Infection prevention and control is a platform to prevent transmission and communicable diseases in healthcare settings. IP Connect 5 components are facility-specific IPC gaps, both physical and knowledge, focused response actions, mass distribution of guidelines, updated training. So this is a application, Android-based application. So this is especially for healthcare providers based in health facilities in South Africa. This application was developed for National Department of Health, South Africa. And through this application, all guidelines are available to the healthcare providers instantly after it released from the source. So real-time data for immediate and accurate action, and comprehensive data collection for risk assessment. Also, one more thing IP Connect does is like any alert regarding any outbreak, infection outbreak, it gives a message to all health facilities under IP Connect network. So these are few screenshots that how convenient this tool is for health care providers to access all the guidelines through their mobile phone. So MDR Doc is a video call based. There are two different ways we used it. Initial stage, we used 3G video calling facility and Skype to make a communication between patient and the doctor. Since the patients were visited by a dot provider every day, and we had to ensure that any adverse drug reactions, especially the serious adverse drug reaction, was experienced by the patient was taken care immediately. So this really worked well. At Bangladesh TB Care 2 project period. So as you can see, a screenshot of communication between a doctor and a patient. And this is symbol-based self-reporting tool for minors. There was a challenge for minors because they do not speak any form of written language. Some minors speak their own language, which doesn't have any written form. So we developed a symbol-based tool, thank you, tool to report by themselves using a smartphone following the symbols only. So this tool ensures that patient taking their medication. Also, it captures video of their taking their medication and stored in the database. So it's and a health manager can view it from the central level or from the regional level. And also, this application allows to report side effects using the symbols, not any kind of written language. So as you can see, it was really convenient, and it's currently under pilot process at South Africa. So e-flip chart is another interesting thing we had. All these things are developed using open source platform, and this electronic tool is used for patient education and counseling. Also, I mean, we had a previous experience from different projects about TB. They don't know about their disease they're suffering from. So the objective is to increase their knowledge, how to prevent TB among family members, and they have two different with screenshots of some images, and also a pre-test and a post-test process to understand that what's the outcome of the whole demonstration. So thank you, and if you have any question, probably we can go to at the end of this session. Thank you.
Thank you. I'm aware that we are running out of time and we still have to have questions, but we're going to have a very short presentation from Dr. Riaz, who is the CEO of an NGO based in Pakistan. He will just share some of the lessons of use of mHealth tools in the management of patients at community level. And let's try to keep to time. Thank you.
Yeah, thank you very much. You know, there is so much talk about mHealth, so let me first give a disclaimer that this product is not for marketing purposes. It's free for everyone. It has been developed in-house and it's under a pilot. So let me first of all introduce what is PPHISN. It's a non-profit company managing more than 1,100 health facilities in Pakistan. It's, we have upgraded around 260 BHUs round the clock, where, the laboratory setting has now been established for TB diagnosis and other things. Solarization has been done, more than 1,500 doctors and 3,500 paramedical staff besides management staff. So program started in 2007. You can see the improvement, 22 million patients a year. So it's a huge opportunity to detect and screen the TB. If you see the improvement in deliveries, there's about 1 lakh deliveries. Similarly, antenatal cases, so is the case with the family planning. And now we are using mHealth. The challenge here is how to integrate the tuberculosis with other primary healthcare services. So what we have done is, we are already practicing the mHealth tools in all different services. So we have just, added tuberculosis in this mHealth tool. So mHealth tool, basically, all monitoring and evaluation services are through IT-based. All resources, drug supplies, education, training, everything is through IT-based. So we have added the TBMIS as an additional service in this. Now, why we have developed this TBMIS? The problem with the primary healthcare facilities at the BHU level is that the doctors are not motivated much. They don't take interest in the tuberculosis. Besides, the TB has become a vertical program. So day by day, when we have started collaborating with the NTP program, we have confronted with the problems and then resolved it through IT solutions. So if you look at the current DHIS, it only gives you the number of TB suspects referred and these two data. These three data were available. So what we have done is we have developed a system whereby the medical doctors are offered the pay for performance, which contains summary of additional indicators, and it includes, apart from 30, in all there are 35 indicators, and the tuberculosis is part of those indicators so that the managers can evaluate and, give feedback and control and monitor. This is the pay for performance dashboard, which says that, there are certain indicators from DHI, summary of additional indicators, how monitors are reporting on various indicators, including tuberculosis, and then what is the skill level of the doctors. So this is how we developed pay for performance dashboard, and then every health facility, all 1,100 health facilities will be evaluated on the basis of this dashboard. Now, how does this, mHealth tuberculosis MIS works? There is a server in the head office, and then there is a community focal person, which is LHW, or a community facilitator, which is interactive SMS alert. And this SMS is also used for community screening. And then, there is this is TB Care Health facility where the lab facility is situated. This is the mobile phone with the doctors. So there is a connection with the community, with the in-charge doctor, and then with the gene expert lab from where the reports are collected. It goes back to the server for analysis. These are different features of the software. Actually, there is no facility of live visit of the software, so I have brought the screenshots. If you look at how software works, it registers the patient. The basic issue in the tuberculosis is the screening and registration. So this, registration, there is a disease categorization, then gender-wise balance, age distribution, investigation of various level, treatment and outcome. So this is the first screenshot of the dashboard. On first look, it gives you a summarized picture of everything, starting from, all indicators, outcome, disease categorization, gender, and all these are interactive. If you place cursor over here, press it, then it gives you the list of the patients like this. The entire profile of the patients, they come out on the dashboard, and you can see as to what is the data about where the patient lives, what is the date of birth. Everything will come on the dashboard. Similarly, last two follow-up cases, they also come on the dashboard if you just click on the, relevant section. Here against, a category 2 case registered where, the relapse has occurred. If you just click on that graph, the detailed list comes out. Similarly, individual patient profile, if you want to see any individual case, there will be a complete profile of the relapsed case or even any other case, whoever is registered on the software. Similarly, under the investigation, you can have all the investigation, and this point is interactive. If you just, push here, then the software will give you the result of each and every patient of CMARE, it looks like this. Similarly, for the treatment and drug collection, and then, rifampin resistance, which is moved, you can get every data on just, clicking. And this is again interactive. If you just press here, category 1, this again gives you the list of the patients. Similarly, for example of screening in the TB-DR cases, screening, the whole result will come like this, just push on that. Similarly, example of the referral will also, give you the details. Regarding the follow-up of drug intake regularity, if you have the patient, it gives you the drug collection date, follow-up appointment date, everything. And here is a case where, who has missed the follow-up, we can issue a SMS to the patient, which says in vernacular language that your medicine is about to end. Similarly, missed dose example, there is a case of Asia who has missed the collection of medicine. Then message will go to everywhere, to the community focal person, to the in-charge doctor, whereby, in-charge doctor can call the patient for coming back and collecting the, medicines from there. Outcomes, all 5 outcomes, they can easily be traced individually. Wherever you click, you can get the list of the concerned patients. This is example of treatment completed, list of patients who has died, and then, reporting format, TB form 4, 7, 8, 9, everything is interactive again, If you just click on the form, it gives you a complete data. And the point which has been mentioned in case of South Africa, as to, this software gives you as to which area the TB prevails more. So what we do is, we highlight that area and do camping in those particular areas by geo-fencing and geopiloting. This is again a screening message which goes to the entire community. If they have a, cough for more than 2 weeks, they can, just press 1 and then message comes back to the server. From there, an active call goes back to the patient for free treatment and free diagnosis. Thank you very much. Thank you.
Thank you very much. I would like to thank you all the presenters. I know that we are running out of time, so maybe we can allow a few questions or comments. Please come forward if you have any question or comment.